Hello, I'm Brenda Kong, and my group members are Emberly Sanchez, Heaven Murphy, and Angelica Perez. And our presentation is about gender bias when it comes to diagnosing personality disorders. So there's many examples of disorders that are more prevalent in men than women, or vice versa. Some of these examples would be narcissistic personality disorder and antisocial personality disorder, that's more diagnosed in men than women, and then dependent, avoidant, and histrionic personality disorders are often more diagnosed in women. So we'll be looking into different possible reasons for why this is the case. Emberly will be talking about narcissistic personality disorder and how the symptoms present differently in men and women. Me and Heaven will both cover borderline personality disorder, and I will cover how the symptoms present in men specifically, while Heaven will talk about how they present in women. And then Angelica will talk about antisocial personality disorder and how the symptoms present differently in each gender as well.
Sex differences in narcissistic personality disorder. It would appear that men are commonly diagnosed with NPD more so than women. The study examining sex differences in narcissistic personality disorder symptoms helped with uncovering the gender-based disparities in the disorder. In the study, researchers performed an audacious 5 interview with roughly 35,000 participants, with 20,000 being female and 15,000 being male. Each of the participants interviewed on the 9 symptoms of NPD. Those who received the diagnosis had to have at least one of the symptoms that cause social or occupational dysfunction. For symptoms lack of empathy, men scored 9% and women scored 4.6%. For symptoms being envious, women scored 4% and men scored 3.2%. And for the symptom sense of entitlement, men scored 6.8% and the women scored 4.0%. It is important to note that even though there are more women than men in the sample size, 7.7% of men received the diagnosis for NPD, while only 4% of women received NPD. The conclusion made from these findings was the result perhaps reflected sex bias in diagnostic criteria, but are indeed consistent with the recent views of NPD being conflated with symptoms that are specific to one's sex. Perhaps adding symptoms that are more reflective of how women are socialized in society may be better accuracy for women getting diagnosed with NPD. Looking at gender disparities in NPD, the same should go for BPD. For men show more symptoms of the disorder, and women show more symptoms of the disorder.
So, as Emberly mentioned, I'll be looking at how symptoms of borderline personality disorder manifest in men specifically and how that might affect them getting a diagnosis. So I found an article in a study done where they took a total group of 511 participants, each divided into 4 separate groups. 2 were controls, 1 for men and 1 for women, and then another 2 groups for those with BPD, and that was also split by gender. So they gave each of these participants a variety of tests that were graded on scales. Each one of these measured a different trait, so impulsivity, aggression, affective lability, severity of depression, and social adjustment. After running these tests, they found that the men with BPD had higher scores for impulsivity and physical aggression. So just looking at the difference in the results, we can make a couple of assumptions on why the men don't typically get diagnosed with BPD as often. So one major factor could be how society perceives men. So a man being more aggressive may be seen as more normal than women, and it's not something that's generally worth raising concern over. There's also the fact that society tends to put a heavy weight on the concept of masculinity, and showing any type of vulnerability or weakness is often frowned upon or ridiculed. So these men may be deterred from asking for the help that they need. And now next we'll have Heaven, who is presenting BPD symptoms and how they show up in women.
So the case study that I chose differs a little bit from everybody else's, where the participants are actually all clinically trained professionals. So they gave all of these participants different case studies, and they had 4 different options where some women had BPD or ASPD and males had BPD or ASPD. In order to make the study a blind study, they also gave every participant an extra case study with schizophrenic diagnoses to rule out poor diagnostic skills. They hypothesized that women were more likely to receive a BPD diagnosis than males with identical symptom presentation. And there was a 72% correct diagnosing of BPD in females and 78% misdiagnosing males with ASPD that actually had BPD. So some of the factors that might contribute to the idea of women being diagnosed more frequently with BPD than males is dependent on the clinician's gender. So women are more likely to diagnose other women with BPD. And sometimes BPD can be misdiagnosed with PTSD from childhood traumas or sexual abuse. And women tend to have 10% higher rates of childhood sexual abuse. And this traumatic event is highly related to the onset of BPD. It's more socially acceptable for young males to show signs of aggressiveness, anger, and sexual impulsivity versus women. It's more normalized. And the strong presentation of aggression and masculine behaviors in BPD directly collides with the diagnosis process that is discussed in Angelica's case study on the presentation of ASPD with regards to the male gender.
Hi, in my case study, there's a study with 323 participants. 253 of them are men and 70 are women. They're all diagnosed with ASPD. Screenings were required for each of these participants to be evaluated, as well as written consent or further research to be done. 21 multiple choice self-reported questionnaires were diagnosed to these patients, and all of them were answered. The Brett impulsivity scale was used, as well as an aggression scale to test their aggression and their impulsivity, as well as a childhood trauma questionnaire to evaluate the proper understanding to why certain behaviors can be showed to be more severe, as well as the impulsivity scale showing no real change. Most of them had the same scoring. Female participants do not present as many antisocial behaviors and less interactions with law enforcement in comparison to the male participants. Female participants also scored higher in childhood trauma questionnaires, as they did receive higher rates of emotional and sexual abuse, as well as our research showing that participants with ASPD presented more symptoms in comparison to the female participants, the male participants. The findings also found that ASPD presented in both genders could be placed in subtypes, as the disorders could not be treated with the same approach. The findings indicate that treatments with ASPD should focus on the following: management of comorbid substance abuse, as well as prevention of antisocial acts. Moving forward to our summary of our whole presentation, Emberly's case study presented a study on the disorder NPD. Although the case study was quite large, the male participant number size was substantially higher than the female participants. The male participants presented much more symptoms that aligned with disorder. In Brenda's case study, we found that there were 4 groups. 2 of them were controls, 1 male and 1 female. And then there are 2 variant groups, which were a male and female that both had BPD. They were clinically tested with surveys and questionnaires to evaluate these symptoms. The males presented higher scores regarding impulsivity and physical aggression. Clinicians were given these case studies in Heavens with 4 diagnosis options, and they compared these case studies regarding the genders and the symptoms that were presented. Different factors or disorders were placed in the case study to prevent any further issues with the research. Moving forward, Heaven's going to be presenting our clinician or our applied findings.
Yeah, so I think that all of our kind of research together shows that there is, in fact, a gender bias among clinicians. I think the research our group has done advocates for a change in the way that clinicians give clinician objectivity. In general, women are often seen as more emotional, and they tend to score higher in rates of neuroticism. Therefore, this can sometimes be a reasoning behind the high rates of misdiagnoses and personality disorders for women. As Emberly mentioned during her presentation, an important factor that could kind of alter these disparities is assessing more women with these diagnoses and reflecting their symptoms throughout the DSM criteria to be more representative of both genders. In the majority of our presentations, I think we all kind of addressed that males showing signs of aggression or impulsivity is more normalized than a woman showing the exact same behaviors. Society has found a way to normalize bad behavior for men and make it seem irrational with women. I also think that, as Angelica stated, the findings in her case study show the treatment of individuals with ASPD tend to be the same for both genders in regards to substance use disorders, but more in depth for males with antisocial behaviors and more in depth with women management of mood and personality disorders. I think this statement about all of this shows the bias based on not only the patient's genders, but also the clinician's genders. Overall, these findings can show the unfairness in the world of diagnosing personality disorders. Moving forward, Emberly is going to present our next questions for future studies.
On to the questions portion of the presentation. It seems that there are many disparities amongst the differing personality disorders, ranging from women being commonly diagnosed with BPD and men being commonly diagnosed with NPD and ASPD. Some questions for further research may include, are the way men and women are socialized in society contribute to their likelihood of receiving a particular personality disorder diagnosis? Does early childhood trauma contribute to the onset of personality disorders? Also, what symptoms can be added to the diagnoses that represent more of how men and women display the disorder? How can clinicians be better equipped to provide proper clinical recommendations in regards to personality disorders presented in genders? And finally, how can clinicians benefit from DSM criteria being more representative of both genders? Overall, it's fair to say that socialization of men and women may play a role in how one gender is diagnosed with one disorder over the other, and should be further expanded on. This concludes Group 18's presentation for gender bias in diagnosing personality disorders. Thank you for listening, and we hope you enjoyed the information shared today. Thanks again.